In this chapter, we will review surgical decision-making for the treatment of intracranial aneurysms. I'd like to acknowledge my co-authors, William Mack and Richard Wynn, the section editors, and the editorial staff at Elsevier that have made this chapter possible. There's a lot to cover in surgical decision-making, so perhaps up front it might be important to emphasize the key points. The primary goal in treating an intracranial aneurysm is complete and permanent occlusion of the aneurysm and at the same time parent artery preservation. There are many techniques that can be used to occlude aneurysms, which broadly can be divided into microsurgical or endovascular techniques, the appropriate selection of which can have a profound impact on outcome and requires a collaborative approach between members of a cerebrovascular team that includes neurosurgeons, endovascular neurosurgeons, and interventional radiologists. In addition, a very clear understanding of the anatomy, physical and physiologic characteristics not only of the patient but also of the techniques allows good decision making. Patient and aneurysm-specific factors are going to influence a choice in how best to treat an aneurysm. This includes the patient's clinical history, an understanding of the natural history of the aneurysm and the patient, and careful review of relevant radiographic studies to fully understand not only the patient's aneurysm morphology, but also the blood vessels associated with that aneurysm. In short, endovascular techniques are associated with better short-term outcomes, particularly in the elderly, whereas surgical techniques are more durable and associated with a better aneurysm occlusion and less aneurysms. Endovascular and surgical techniques should not be looked at as separate techniques or in isolation or as competing techniques, but rather as supplementary and complementary. And this is particularly true in the more complex aneurysms, such as giant or fusiform aneurysms. And paradoxically, one might also include the blister or microaneurysms. And here, techniques can often be used in combination. Techniques continue to evolve, and the recent introduction of flow diverting stents, for example, pipeline, has significantly enhanced our ability to treat many of these complex aneurysms. We'll cover a handful of topics: treatment efficacy for unruptured aneurysm and the risk of treatment, how one should manage a ruptured aneurysm, and this includes a brief review of the timing of treatment, special circumstances, for example, advanced age or giant aneurysms, how best to appropriately select surgical endovascular techniques, and then how best to train cerebrovascular surgeons for the future, since recent analysis of administrative databases shows a decline in the number of surgical procedures as endovascular techniques have. There are more aneurysms identified than there are subarachnoid hemorrhage, perhaps a six-fold difference. But occluding an aneurysm before it's ruptured is one strategy to improve outcome in patients with subarachnoid hemorrhage. Aneurysm occlusion, however, is associated with risk. And how does one appropriately select a patient and their aneurysm for treatment? There are several aneurysm-specific factors that are associated with aneurysm rupture. The most well-known is increased size, and in general, an aneurysm greater than 7 millimeters in size is associated with a higher risk of rupture, and that risk increases the larger the aneurysm becomes. An irregular shape, similarly, predicts a higher risk of outcome, as does aneurysm location. For example, the risk is higher in the posterior circulation and at the anterior communicating artery, whereas risk seems to be lower with middle cerebral artery aneurysms. Other features, such as how blood flows into the aneurysm, whether it's symptomatic or associated with AVMs, if there's been a previous subarachnoid hemorrhage, a high aspect ratio, and an increase in aneurysm size on follow-up imaging all are associated with an increased risk of rupture. Advances in radiologic techniques that allow evaluation for aneurysmal wall enhancement or with flow analysis if wall shear stress is identified can also be used to predict if an aneurysm. There are patient-specific factors and other factors that also are associated with rupture. This includes increased age, cigarette smoking, hypertension, binge alcohol drinking, the use of symptomatic drugs, and a family history of subarachnoid hemorrhage. There also are factors that we have no control over, such as atmospheric pressure, seasonal variation, and even slopes. Understanding which patient is at risk helps determine who should be treated. And this has been perhaps codified through various scoring systems. Phases, which looks at the population being, i.e. the patient, whether there's hypertension, patient age, aneurysm size, has there been a previous subarachnoid hemorrhage, and aneurysm location. A score greater than 3 predicts a higher risk of rupture. The UIATS model, the Unruptured Intracranial Aneurysm Treatment Score, which is derived through a Delphi process and consensus among various experts, helps decide whether an aneurysm should be treated or not. It doesn't necessarily tell you which treatment to use, but by adding up these scores, which are patient-related, aneurysm-related, and treatment-related, one can get a score that either favors repair or favors. Surgery for unruptured intracranial aneurysms is successful. More than 90% of unruptured aneurysms can be successfully occluded, but the success rate is influenced by many variables, and in particular, aneurysm size. In general, the smaller the aneurysm, the higher the success, the lower the risk. But larger aneurysms and older patients tend to do worse. As indicated earlier, the primary goal of aneurysm surgery is permanent aneurysm occlusion. If complete aneurysm occlusion is documented on postoperative angiography, the likelihood of recurrence for practical purposes is 0. But a residual, particularly a small dog ear, is associated with a small chance of recurrence and also aneurysm rupture. And this cumulative risk in meta-analytic studies over 10 years is up to 3%. But, as emphasized before, this risk is increased when the aneurysm is incompletely occluded. Importantly, patients who've undergone aneurysm surgery actually have a higher annual risk of stroke compared to the general population, and this speaks to the vascular pathology that underlies it. It is important to understand surgical risk. Like success, surgical risk is size and location dependent. In general, smaller aneurysms have a much lower risk, particularly small aneurysms in the anterior circulation. Aneurysms greater than 25 millimeters have a nearly 5-fold greater risk compared to a 5 millimeter aneurysm. And so the risk of operative mortality is perhaps less than 2% for small aneurysms, i.e. less than 5 millimeters, but in the order of 15% in large aneurysms, i.e. greater than 16 millimeters. Just as risk is lower with small aneurysms, clip occlusion is greater with small aneurysms. And accordingly, scores have been derived to try and predict surgical risk. And here you can see this score includes patient age, aneurysm size, aneurysm location. And a young patient with a small anterior circulation aneurysm, nearly 100% are going to do well. Conversely, in a patient more than 60 with a giant aneurysm, that's a complex giant aneurysm in the posterior circulation, the likelihood of morbidity approaches 60 or more. So which aneurysms, unruptured aneurysms, should be treated? An unruptured aneurysm where there has been a subarachnoid hemorrhage from another aneurysm ideally should be treated. The timing of that relative to the recovery from the subarachnoid hemorrhage is still to be fully defined. A symptomatic aneurysm, particularly an aneurysm that's enlarging on follow-up imaging. Aneurysms more than 7 millimeters in size, particularly if life expectancy is 12 or more years. One might consider including an aneurysm more than 5 millimeters in size if the patient is very young or middle-aged. Conversely, small aneurysms, less than 5 millimeters in size, can be managed conservatively. The exception to this may be in those patients with a positive family history or who are current cigarette smokers. In general, aneurysms in the cavernous carotid region do not require treatment unless they become symptomatic. Ideally, these aneurysms should be treated at high-volume centers. This is a recommendation from the American Heart Association, the Neurocritical Care Society. However, what defines a high-volume center is not very clear, but perhaps more than 20 unruptured intracranial aneurysm procedures each year. Aneurysms rupture. There's geographic variation, with higher risk in certain populations compared to others. What affects outcome is dependent on the patient, the aneurysm, the institution, and also the geography in which that patient finds him or herself. As physicians and healthcare providers, what we do can also have a profound influence on outcome. And this is where surgical decision-making plays a role, because how the aneurysm is occluded using endovascular or surgical techniques can have a profound impact both on the short and long-term outcome. Included in this is the timing of aneurysm occlusion to prevent rebleeding, and how other factors, such as intracranial hypertension, intracerebral hemorrhage, intraventricular hemorrhage, or vasospasm are managed. In other words, simple occlusion of an aneurysm in the absence of good neurocritical care is not going to make a difference to outcome. Rebleeding is why aneurysm occlusion is necessary. In addition, aneurysm occlusion facilitates management of vasospasm and other medical complications. Rebleeding is common, and rates between 4 and 15% are described in the first 24 hours, and then somewhere between 1 and 2% per day during the subsequent 4 weeks. If rebleeding occurs, mortality is high. In the order of 70 to 90% of patients die, particularly those who are already in poor clinical grade. Factors that predict rebleeding include premorbid hypertension, poor clinical grade, higher blood pressure at administration, abnormal hemostatic parameters, and worse subarachnoid hemorrhage. In addition, larger aneurysms and posterior circulation aneurysms have a higher risk of rupture. Hence, not surprisingly, the factors that are associated with long-term outcome include rebleeding, the initial hemorrhage, vasospasm, and the development of medical complications. So timing of surgery plays an important role in patient outcome. There are no robust or large multi-center randomized trials that have evaluated the concept of timing of surgery. Our approach is derived largely from prospective epidemiological data. Costas, published now almost 30 years ago, showed that patients who had surgery, and these are patients with anterior circulation aneurysms, between 0 and 3 days, had a superior outcome to those who had delayed surgery. Worst outcome was seen in patients who had surgery between 4 and 10 days during the maximal phase of vasospasm. ISAT, which was published now almost 18 years ago, the International Subarachnoid Hemorrhage Trial, was a randomized trial that evaluated endovascular or surgical techniques in patients where there was clinical equipoise about how best to occlude the aneurysm. The outcome appeared to be worse in those who had surgery or aneurysm occlusion more than 10 days after aneurysm rupture, i.e. there's value to early intervention. That early intervention was facilitated by using endovascular techniques. The effect of rebleeding is more pronounced for coiling than clipping. So small studies have suggested that patients who undergo treatment within 24 hours are more likely to have a better outcome, particularly if coiling can be achieved within 24 hours. However, the role of ultra-early aneurysm occlusion, i.e. less than 6 or less than 12 or even less than 24 hours after aneurysm rupture, has still to be fully elucidated. In addition, the optimal timing of flow diversion or endovascular techniques where antiplatelet agents are used, or the occlusion of complex aneurysms where bypass procedures are necessary, is also something that requires further rigor. Over time, there's been a decline in subarachnoid hemorrhage mortality. Not necessarily a change in outcome, though. And that's interesting because administrative databases suggest the severity of subarachnoid hemorrhage among patients admitted to hospital has increased. That may speak to the improvement in pre-hospital care and resuscitation and neurocritical care. Poor-grade subarachnoid hemorrhage is well known to be associated with worse outcome. How to manage these patients requires a multidisciplinary team, not only how best to occlude the aneurysm, but also neurocritical care. Among the dilemmas is what to do with a large intracerebral hemorrhage associated with an aneurysm rupture. There is observational data that suggests these patients should undergo surgery with simultaneous aneurysm occlusion, and even in the moribund patient, if done in a timely fashion, can have a positive impact on outcome. Many of these patients may require decompressive hemicraniectomy and later reconstruction of their skull. They remain unknowns. In other words, could endovascular aneurysm occlusion be performed first and then hematoma evacuation performed? Or should endovascular aneurysm occlusion and a decompressive hemicraniectomy suffice? Some observational data suggests that the time the hemorrhage is evacuated, a decompressive hemicraniectomy should be performed de novo rather than wait until delayed cerebral edema or intracranial hypertension. What is very clear is that effective management of the consequences of the hemorrhage, i.e. the development of intracranial pressure, can make a profound difference to outcome. In patients who have normal ICP, the likelihood of a favorable outcome is good. This applies to both good and poor-grade patients. On the other hand, patients with very high intracranial pressure, and high here defined greater than 50, are far more likely to die or have a poor outcome. Interestingly, among these patients who have very markedly elevated intracranial pressure, if they respond to treatment, for example, if mannitol is administered and the intracranial pressure normalizes, they have a good 30-40% chance of a favorable outcome. By contrast, if they have high intracranial pressure greater than 50 and do not respond to mannitol or some other form of treatment, universally these patients have a poor outcome or die. This is a suggested algorithm for patients with poor-grade subarachnoid hemorrhage. The basics of care, or the ABCs of care, are important, and then imaging, and in some circumstances just a head CT and CTA may be sufficient, because in the unstable moribund patient there is some observational data suggests that emergency craniotomy with intracerebral hemorrhage evacuation and aneurysm occlusion can help improve outcome, although many of these patients are still significantly disabled. In a patient who's not clinically deteriorating, how one manages them may depend on the presence of an intracerebral hemorrhage, subarachnoid hemorrhage, intraventricular hemorrhage, or hydrocephalus. In many, insertion of a ventriculostomy before an angiogram can be helpful. In those who have markedly elevated intracranial pressure, for example, greater than 30, and it's not controllable, in the elderly, more than 65, or those who have multiple medical problems, withdrawal of care may be appropriate. In younger patients, or those who have ICP that's controlled, aneurysm occlusion is then indicated, the choice of which craniotomy or endovascular aneurysm occlusion may then depend on specific morphologic features of the aneurysm. Importantly, all these patients should be reassessed after 3 to 5 days. In those patients who've not demonstrated an improvement clinically or who have poorly controlled intracranial pressure with an evolution of low density on CT, inevitably have a bad outcome, and it may be appropriate to withdraw care in those patients. Those who survive undergo rehabilitation, and at 6 months, follow-up studies should be obtained to be certain that there's complete aneurysm occlusion. ISAT, published back in 2002, with the International Subarachnoid Hemorrhage Trial, attempted to evaluate which technique, i.e. neurosurgical clipping or endovascular coiling, was better for patients with subarachnoid hemorrhage. And in this circumstance, this was endosaccular coiling. Adjunctive procedures such as stent-assisted coiling, balloon-assisted coiling, or flow diverters were not used in ISAT. Over 2,000 patients were randomized. Most of these patients had small anterior circulation aneurysms. What ISAT demonstrated that at 1 year, patients who underwent coiling had a better outcome than those who underwent. However, subsequent analysis at 5 and 10 years later demonstrated that those patients who had coiling had a greater risk of rebleeding because of either residual or recurrent. And hence, in the younger patient, ultimately, surgical occlusion might be favored, whereas in the older patient, endovascular occlusion or coiling might be preferred. This is true in unruptured aneurysms. Aneurysm occlusion, as mentioned before, cannot occur in isolation. The subarachnoid hemorrhage itself requires management. This requires dedicated critical care. Recommendations from the American Heart Association and the Neurocritical Care Society are that patients with subarachnoid hemorrhage should be cared for in cerebrovascular centers where both endovascular and microsurgical techniques are available, and critical care is also available. The patient should be assessed for both endovascular or surgical aneurysm occlusion to determine which is applicable to that individual. When both are feasible in the short term, endovascular techniques might be the better alternative. How one decides on aneurysm occlusion or when to do aneurysm occlusion plays a role, and certain factors such as the presence or absence of an intracerebral hemorrhage might have an influence on that decision. Both surgical and endovascular techniques are evolving, and hence continued academic evaluation remains important to fully understand the impact. There are several special circumstances that require consideration. Aneurysms identified during pregnancy, those found in children, or those in elderly patients. Particularly aneurysms such as infective and traumatic aneurysms are different from the regular saccular aneurysms that are treated, as are aneurysms that are associated with AVMs or carotid artery disease. In addition, certain aneurysm morphologies such as fusiform, giant, micro or blister aneurysms, and residual aneurysms all need special consideration before deciding on how to occlude them. Briefly, advanced age. It's becoming an increasingly important question because life expectancy is increasing. It is well documented that advanced age remains a risk factor, not only for aneurysm formation, but also poor outcome after subarachnoid hemorrhage or during repair of an aneurysm, including repair of an unruptured intracranial aneurysm. Now, Some of that risk is because patients have comorbid conditions and medical complications play a role in the outcome. But older patients are more likely to have significant atherosclerosis or calcified aneurysms. ISHUA, which was the International Study of Unruptured Intracranial Aneurysms, did demonstrate that aneurysm occlusion was of benefit in elderly patients, particularly if endovascular techniques were used, but not surgical techniques. And hence, as a general rule, in older patients, endovascular techniques might be preferred to surgical techniques, although this may well depend on specific aneurysm characteristics. Giant aneurysms are different. They're more difficult to treat. They're associated with a higher risk of rupture. But in a very simple way of looking at their treatment surgically, philosophically, one should consider occlusion of the aneurysm as less important than reconstruction of the vessel. And that allows effective strategies to be designed to close the aneurysm. And for example, in this illustration here, you can see how these right-angled fenestrated clips are placed along the neck to reconstruct the vessel, and in so doing include the aneurysm from the circulation. A variety of other clip configurations can be used with the same goal, that is, reconstruct the vessel, and in so doing occlude the. Similarly, more sophisticated techniques, and this is a complex middle cerebral artery bifurcation aneurysm that incorporates the parent vessel and the two bifurcating vessels. Here what's occurred is the aneurysm is excised and reconstructed under temporary occlusion, and the vessel resewn to reconstruct the vessels. Endovascular techniques can also be used to occlude giant aneurysms. But coiling alone may not often work in these vessels, in these aneurysms. And here, adjunctive procedures such as parent vessel occlusion with balloons or coils, or selective coil occlusion with adjunctive techniques using a balloon or a stent become important. Parent vessel reconstruction with a flow diverter such as pipeline, or parent vessel occlusion after bypass surgery, all strategies that can be used to occlude giant. Fusiform aneurysms are another specific group that require careful consideration. Here too, it's more about parent vessel reconstruction than it is about aneurysm occlusion. And in this illustration, you can see a fusiform aneurysm in the vertebrobasilar complex has been reconstructed using a right-angled fenestrated clip to create a normal parent vessel. Fusiform aneurysms are common in the posterior circulation, and this algorithm has been suggested for a management approach to these complex aneurysms. When incidentally found and small, defined as less than 10 millimeters, observation alone might be sufficient. Larger than 10 millimeters, where there's mass effect or subarachnoid hemorrhage, how best to treat that aneurysm may depend on where it's located. In other words, does it involve the whole basilar artery? Is it related to pica? Or is it the vertebrobasilar junction? There, treatment may be influenced by the location, and SAC-associated coiling or flow diverters become necessary. Bypass is also often required when trapping is to be performed. On the other hand, if patients are symptomatic because of ischemic causes, antiplatelet agents or anticoagulation may suffice in some patients. What's revolutionized our care of these complex aneurysms has been the evolution of flow diverters, for example, pipeline. And here's an example of a complex basilar aneurysm that with flow diversion has led to absence of the. Many studies have been reported in the last several years that have looked at various flow diverters, including pipeline. Many of these are observational studies. There's been a small randomized trial that's been performed. As a general rule, these registries and observational data suggest that pipeline is an effective means to occlude complex aneurysms with a low risk and a low recurrence rate. The indications for flow diversion have evolved from giant and complex proximal internal carotid artery aneurysms to include posterior circulation aneurysms, more distal aneurysms, and even blister or microaneurysms. The results of endosaccular occlusion using GDC coils is similar to that with surgery. That is, small aneurysms can be occluded with greater frequency, and in particular, small aneurysms with small necks. The likelihood of occluding a giant aneurysm with a large neck using just coils is perhaps less than 30%. By contrast, the likelihood of occluding an aneurysm with just coils in a small aneurysm defined as less than 10 millimeters with a small neck is greater than 80%. There are several factors that can limit the successful endosaccular aneurysm occlusion using GDC coils. That is, a dome-to-neck ratio less than 2, a wide neck, more than 4 millimeters, poor access, and this might be because of atherosclerosis in blood vessels or apparent blood vessels, an unstable intraluminal thrombosis, perhaps less successful in the middle cerebral artery, and small aneurysms. Now, in these circumstances, adjunctive techniques such as stent-assisted coiling or flow diversion becomes important. Importantly, aneurysms should be followed over time because there is a suggestion that they can recur, particularly after endovascular techniques and less so with surgical techniques. The cumulative likelihood of rebleeding is that much higher when using endovascular technique. And this has been demonstrated in CARROT, which was the cerebral aneurysm re-rupture after treatment study, which was an observational study. And the annual rate of retreatment after coiling was around 13% in the first year compared to about 2.5% with surgical clipping. Beyond a year, no patients had undergone microsurgical procedures required a second treatment, whereas this was close to 5% after coiling. So looked at over time, again, just as with the success of surgery or endosaccular occlusion, small aneurysms with small neck have a much lower likelihood of recurring, whereas giant aneurysms, and particularly giant aneurysms with large necks, have a much higher risk of recurring. It is in these patients that adjunctive techniques such as stent-assisted coiling become important to help occlude the aneurysm. In addition, flow diversion is evolving and really helping to change how best to manage these patients. There are alternative strategies, such as parent vessel occlusion, which might be used for giant proximal internal carotid artery aneurysms, dissecting aneurysms or serpentine middle cerebral artery aneurysms, aneurysm trapping, which requires an understanding of whether they're collaterals or if revascularization is necessary. Revascularization could be an interposition graft or a bypass graft. Hypothermic circulatory arrest can be used for giant aneurysms. This is perhaps far less frequently used today than 20 years ago, in large part because surgical techniques have evolved, but more importantly, endovascular techniques have evolved. Finally, strategies such as aneurysm excision and reconstruction can be used in the middle cerebral artery distribution in particular, and also when traumatic aneurysms are treated. As mentioned before, endovascular techniques and surgical techniques are not two distinct entities. They're supplementary, they're complementary. They can be combined to effectively treat a patient. And here's an individual with a very large, complex proximal internal carotid artery aneurysm where a bypass has been performed and then the carotid artery occluded using endovascular techniques. Aneurysms, ideally, whether they're unraptured or subarachnoid, should be treated in institutions where there's high volume. Exactly what defines high volume is not clear. And most of the data that's looked at this question has been a retrospective analysis of administrative databases which come with a variety of inherent biases, in particular, not necessarily being able to stratify patient risk. But as a general rule, patients at higher volume versus very low volume hospitals do better. And that high volume is defined anywhere between more than 20 or more than 35 cases per year. What may be more important than the volume per se is the frequency with which the procedures are performed. And this effect is perhaps greater in patients with unruptured aneurysms than it is with subarachnoid hemorrhage. But having said that, as your volume of patients with subarachnoid hemorrhage decreases from more than 100 per year, the likelihood of mortality increases, although it does seem that there might be a U-shaped curve. Having said that, current American Heart Association and Neurocritical Care Guidelines all recommend that subarachnoid hemorrhage patient should be transferred to centers where there is both surgical and endovascular techniques and dedicated neurointensive care unit. But at the same time as we recognize that volume is important, volume of surgical procedures is declining, in large part because endovascular techniques have evolved. Endovascular techniques are now used more frequently. So how then do we train surgeons for the future? Because surgical techniques are still necessary. How do we train them when the volume is decreasing? And some of that is also related to restricted work hours. So tools have evolved, which include using video archives, simulation, haptic feedback, robotics, and a variety of performance evaluation tools with more objective criteria, such as objective structured assessment of technical skills. And this is being further refined specifically to aneurysms with tools such as objective structured assessment of aneurysm clipping skills or skill assessment of microsurgery for brain aneurysms. More to come. But it does seem that vascular surgeons trained in accredited fellowship programs are adequately trained. But it's important to recognize that as our techniques evolve, so too does the education of cerebrovascular surgeons have to evolve, because the decision-making and how best to occlude an aneurysm does have a profound impact on outcome. Thank you.